So we are in week 5, probably of all the areas in pediatrics and even adults. I love hearts. I love lungs. I like everything about it, and it makes sense. So I'm going to try to pull it apart and that you can understand it a little bit easier. So this week is chapters 40 and 42, respiratory and cardiac. And know that you do have a discussion question, and there is a CJ Sims due. Know that those are both the CJ Sims is worth quite a bit of percentage. So if you haven't done them, you get little messages, get them in because they do add up quickly. Not doing NCLEX or not doing CJ Sims. So I'll be sending messages, and so will Professor Luminoso to get them done. So the way I run classes, we just had a little mini break really after the quiz for you to get what you needed to get done or a snack or whatever. During class, I go straight through. I'm going to do a PowerPoint and then I'm going to turn it right into Cahoots, and we're probably going to get out a couple minutes earlier. So instead of breaking, my class has decided just to get out earlier in the class. So that's what we're going to do today, okay? So I know that you all probably have gotten the PowerPoint. If you haven't, what I'll do is I will post this in your announcements for Professor Luminoso so that you're going to get it pretty quick. Some students look at this stuff and go, oh my goodness, I need to look at this because it's not making sense. And try to review it pretty quickly. So that's what I'm going to do for you. So remember, heart and lungs go together. If you don't have a good heart pumping, you're not going to be oxygenated. And if your lungs are damaged, your heart's going to be working harder because the lungs pumping the blood through there. So just think about heart and lungs and the way that they function. You need your lungs because you need oxygen and you need oxygen to breathe, to live. So some of the things that affect children are whether they're upper airway or lower airway type of problems. Children always, they have mucus in their nose. You're always blowing their nose, or they're always, wiping it on their shirt and everywhere, right? So upper airway, we have issues. Now, lower airway is what we would consider more of your asthma because it's the lower alveoli that are in spasm and we can't get any air back. It's like respiratory wheezing. And pneumonias. Pneumonias usually are in lower lobes, left lower lobe, or sometimes middle lobe, but they're on the lower ends of the respiratory tract. Now, children, and then this is a great season for it right now. Um, Children, most of the time, they are the cough, cold, runny nose, lots and lots of mucus, little fever, just feeling miserable. Most of the time, it's a virus. So you get a child, the temperature's 104 and you're concerned, and you bring them over to the doctor, and it's been at 24 hours since it started. And the doctor will say, oh, you have an upper respiratory infection, maybe order you some cough medicine and tell you, treat the fever. Acetaminophen, ibuprofen, and alternate it. Increase fluids and plenty of rest. And no antibiotics because you don't give antibiotics for a fever and a virus. You only give it with a fever with bacteria. So there are some times it can turn into other stuff, but most of the time it is a virus. Now, there's one time that we will treat a virus, and it's called that RSV virus, that respiratory syncytial virus. And we only will treat it in a child less than 1 year old. And that child usually is going to be treated from birth because they have other problems. Prematurity is a big one. Lungs aren't really formed all of that well. A cardiac child, cystic fibrosis, a child with any immunosuppressive disease that a little bit of a virus, extra mucus in their nose is too much for them to handle. This child is going to be getting an immunization every single month for the first year of life because that extra mucus in their nose, they can't breathe. What does babies do? They suck, swallow, and breathe, and barely that. And they're obligatory nose breathers. So you put mucus in there. Can they suck, swallow, and breathe? So it becomes a feeding problem. And of course, tachypnea, et cetera, et cetera. So we're going to go into that a little bit more, but just remember, RSV babies, serious because of the mucus. As you get older, we can blow noses. So children are not that bad, the older than one. And of course, adults is your common cold that you just don't feel good at all. Well, children, infants, let's look about how they deal with disease. The younger children, yes, they're getting immunizations. Yes, if they're breastfed, they're getting mom's antibodies. But again, they're still dependent up till about age 3 months, only on mom. That's why, if you've noticed the immunization schedule, 2, 4, 6 months, big time immunizations, 4 at a time, right? And it's like, why are we doing that? Well, mom stuff is wearing off. And these infections are very dangerous and life-threatening if we don't put them at least minimally getting it or preventing them from getting these infections. Now, babies after 3 months old, they're going to start getting more sickness. They're around more people. They end up going to daycare and stuff. Like usually it's after that maternity care, leave, right? Now you're putting these kids in the daycare, and they're starting to get all of these, different diseases. And they're catching, and they're always ear infections, upper respiratory, chronic. It's because their bodies now are being introduced, and especially toddlers. What do toddlers do at daycare all day long? They play. And it's swapping spit all day long, from me to toy to that to toy, as clean as these people can be. Toddlers are going to go from toy to toy. Now, is it a bad thing? Well, think about it. By the time they get to school, they've had every disease known on the planet because they've swapped everybody's spit for how many years, and they have had all these illnesses. Now their bodies are built up, all of this immune good stuff. So by the time they get to school, they're only getting bacterial type diseases because they probably run through all of these viral illnesses, and they've gotten all of these antibodies and antigens built up now. So again, it just says increased immunity with age because of all of that. Now, children, biggest thing, ear infections. Why? Well, what did I just say about kids and being young? They don't know how to blow their noses. They have all this mucus. Where's the area of least resistance? Up these short, narrow, wide eustachian tubes into the ears, and that's why there's all of these middle ear infections. Probably the most common of all infections are the ears. Anything in the mouth and mouth related is bacteria. You have staph in your mouth and your nose all the time. So it goes into the ears, and then it creates the pain, the bulging, etc. And treatment. Well, we're going to be treating it with an antibiotic. First one is usually amoxicillin. Simple. And it's twice a day, 7 to 10 days, depending on the doctor. Now, if it's chronically getting bad, they're going to consider tubes. I still have a tube in my right ear. That's how bad I get with everything and mucus going into my ears just from allergies or whatnot. So it is a relief. It drains the mucus and it prevents that chronic ear pain, etc. So first of all, you'll do medical antibiotics that don't work, then they'll go for tubes in the ear. And I had my done in a doctor's office. Children go into hospital and are put under anesthesia because they're not going to sit still when you can hear the knife crunching the eardrum. When you put the suction catheter and they suction out extra mucus, I heard all this stuff. To get it out, a child would not ever lay there. And when I got up, I was like dizzy and wanted to fall over. So, no, we wouldn't do that to children. We do that to adults like me, right? Why does it happen? Like I said, it's short, it's close, it's wide open, area of least resistance. Mucus not going out, and you're not swallowing it into the ears. So, what does a kid look like when they're sick? I think when a kid has a fever, you can tell almost instantly. Number one, they're not going to eat their favorite food, their favorite juice. They don't want anything, or they're not playing. They're sitting in the corner. Sometimes they're banging their head, the younger kids, or they're showing you hands and mouth, the location of what's going on. But these children, if they're in pain, they're going to show you somehow. An older kid can say, my ear. A younger kid will show you by banging or in the mouth, my throat hurts, right? And we know that child has a fever, just like you have a fever, you're going to medicate because children, once the fever comes down, will start eating and drinking. And what do you need to do to treat a fever? You need extra fluids. So you medicate. You give acetaminophen, you give ibuprofen. The child is going to feel a little bit better, and you can at least get some fluids in them, is what they need. When that fever's down, the kid is a little bit more active, and I think parents feel better just to see their kid up and moving and not sitting in the corner, right? So how do we take care? Upper respiratory. Well, anything that has to do with mucus that's causing coughing, you always want to make them to breathe as easy as we can. We want them to be able to rest at night. I mean, bronchitis is probably the worst because that's when you're barking this dry cough all night. So that's another story. We know children need to be taught using tissues, wash hands, the arm and their elbows, all of those things. I think it's one of the first things that my grandson learned in preschool is how to put his arm up and to cough in it. And he came home and does it. And I'm like, oh, look at him. He knows how to do it. And that was at age 4. When the temperature's down, they'll be able to hydrate. They'll be able to eat better. And of course, children that don't feel well with a fever, they just want a hug. They just want to know that they don't feel well, that they get extra hugs. Now, mononucleosis, not a big deal, right? Kissing disease. That's what we call it. But really, what is it? It is a virus. So it's not an antibiotic, it's virus. It's a herpes-like Epstein-Barr virus. Well, Epstein-Barr is the fatigue syndrome. Like you don't want to get up and move, you have overall exhaustion. It's part of Epstein-Barr, okay? Also, these children, when they come in, before they get this diagnosis, because parents have no clue this is what's going to happen, they come in with flu-like symptoms, swollen glands, sore throat, fever, maybe a rash, maybe not, okay? They come in and the doctor takes culture, strep, no. They take a culture, it's negative, and they treat them as a viral pharyngitis, send them home. Three days later, the kid's still not well. They call the doctor or they go in, and he says, well, let's just order some antibiotics. Maybe there's something we missed. Maybe it wasn't cooked enough yet to show a culture. All right, start antibiotics. 3 days later, they come to my ER, and now they're 6 days out of the first and the sore throat and the first visit with the doctor. So, physician comes in, gets the history. Sore throat, it's viral, still feels horrible, still swollen lymph glands. Now we're going to draw blood. We're going to draw two things. Number one is CBC. Why is CBC? I want to check the white count for infection. That would make it bacterial. And the second test is a monospot test. It's going to tell me mononucleosis virus, which is what this is sounding like. Okay. Comes back, white count is 6, it's normal. We get monospot, positive. All right, now we know the treatment. How do we treat a viral diagnosis? Acetaminophen, ibuprofen, rest, extra fluids, but their spleen and liver can be swollen like a big balloon. And if it gets hit in a certain way, it can burst, and these children can die. So we will send them home. Explicit instructions. Please, no exercise. Protect that abdomen. You have brothers and sisters at home. No roughhousing. Protect that abdomen. It can burst. Now I'm going to tell you a real story, and it still hurts me. I had a little boy, he was 8 or 9 years old, came in with his father. This story, exactly what happened with giving antibiotics, gone to the doctors, and came to me. Did it, he was monospot. the doctor and I both did a really big detailed about how to send him home and that he needed to get clearance from pediatrician in about 3 weeks if he could play sports by then. Well, the father got from the doctor because I listened. When I gave him, I made sure again to tell him 1 week later, I am now the primary trauma nurse on duty, which means anything that comes on a helicopter, I'm the nurse in charge. That little boy was on there and he was dead on arrival. He was out on an ATV in the Everglades, fell off and his abdomen and died. His spleen ruptured. I still today feel horrible about it. So, anybody gets a child with mononucleosis, tell them please to protect their belly and no roughhousing or sports, no contact sports for 3 weeks minimum until they get the clear from their physician. I think you'll remember that one. Now, that bronchitis, I told you that thing that bothers you. This keeps you awake all night long. And there's nothing coming up. It's this dry. Your throat hurts from coughing so much. Your ribs hurt from coughing so much. And especially at night when you try to sleep, it's the worst. It is described a dry, hacking cough, non productive, that worsens at night. How do we treat it? Well, most likely you don't have a fever. It's usually a virus, they consider it, so usually not antibiotics, but if anybody's ever had bronchitis, the doctors always order you a Z-Pack. Why? I don't know, but it's a virus usually. They'll give you acetaminophen or ibuprofen for just discomfort, general body aches, and they will tell you some sort of cough suppressant. Usually, some sort of narcotic codeine type of cough suppressant is the best, but today it's so hard to get it. They've taken a lot of these, or they're not producing, or something on the market with it. So cough suppressants, cough drops, humidity, all of that to try to, liquefy that, airway and undry it to try to help it. But this is just an annoying night. Now, croup. This is when the kids bark like a seal. You can tell this bark from anywhere. You can be in a grocery store and they're in the fruit and you're in the bakery. You can tell them from across the store, oh, that kid is croup. Sounds very distinctive. Now, what is croup? The upper airway swells and you can't get air in. And when you try to cough, because it irritates, it barks because of the swelling of the larynx and the upper airway structure. Okay. So, croup, it is this barking. Usually, it is not a fever. It's younger children. As I said, it's usually a virus that goes on with it. It's upper airway with air going in, so it's inspiratory. If as the swelling gets more, then you're going to see those retractions. If you do not treat it, it's going to get to the point of respiratory distress and hypoxia, and it could lead into epiglottitis, which is the worst thing that can happen. Acute epiglottitis is when croup, left untreated, swells the whole epiglottis, which is that leaf-like structure that covers your larynx. When you take a breath in, you can't get it in the larynx. That epiglottis is covering it. And usually these children, they move around and find like that tripod, like old people do with COPD. They find that place. There's one little place they can breathe at, and they don't move. And you'll see them drooling. They can't swallow. Their voice, because it's so, swollen inside there. And you can see all the signs of respiratory distress. It could be nasal flaring on younger children. You can see that, supraclavicular, intercostal, just your shoulders up to tachypnea. These really, they cannot breathe. So this is an obstruction due to a piece of tissue that is swollen. So guess what you think you need to be aware of and prevent? Well, that is that complete obstruction. So this is one that you would tell who's working with you, Go get the intubation cart and the tracheostomy tray, place it at the bedside. This child might even go into the trauma room where all that stuff is, depending on how severe, and if the nurse picks up on it in the triage, getting them into a room. So, what do? It's swelling of tissue. You need anti-inflammatories. You're going to give an aerosol with epinephrine in it called racemic epi. And that puts epinephrine right in on that epiglottis to stop the swelling. And you're going to get an IV in them and get them some IV steroids, Solumedrol. At the same time, you're giving that racemic B. When that's done, you're going to be giving some sort of misty, humidified oxygen or air, whatever they need to soothe that throat and open it up. But the big thing with epiglottitis is maintaining the airway. You make sure you get in that airway equipment in case that child stops breathing, and know that you're going to grab albuterol, yes, but you're going to grab racemic epi also. And it's this little tiny itsy bitsy amount, and you get it right into them, and it works so quick. It's great. Okay, RSV. Again, I've talked about it. This is infants, 1 year and less. Infants, it's described as up to 1 year, the first 28 days being neonatal period, okay? So RSV is not a big deal. It's a common cold. It's a virus. It happens all the time, right? But for young kids, like I said, that really have already issues, they don't need anything else to make their body work harder. I mean, congenital heart defects, a child that already was premature, that's already on oxygen because of their lungs, with long-term ventilation or whatever, right? So this child is going to be getting something called Synagist, also called Pavizimab. It's a biologic. This is once a month, only the first year. And this helps prevent a child from getting RSV. You need to know that name. You're going to see it come up all over the place. You'll see it on exams, you'll see it on HESIs, and I know you'll see it on NCLEX. That's why you have that matching with all the key terms you need from these two chapters. All right, upper airway, children. You think TNA is all the big thing, right? Big surgery. Usually it's tonsil adenoids and, ears tubes all at the same time. So how do we take care of and how do we teach our parents and children, if they're old enough, how to take care of themselves post-operatively? Well, after surgery, they should be told to avoid irritating and highly seasoned food. I think the funniest thing is my brother had it done many, 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 many years ago, of course, in the doctor's office. And when he got home, he wanted a radish with salt on it. And the doctor says, well, if he wants it and eats it, the salt's okay, let him have it. But a radish and salt, well, it's not the best thing to use. Something, of course, good old chicken soup is always the best, right? No gargling or vigorous toothbrushing. A tonsillectomy, you don't think it's a big deal, but there's these two big pieces of tissue that they cut out. And then they cauterize the area. There's scabs. Like when you fall down and you scab yourself on your knee, well, it's like that inside your body. So if anything, it's going to knock off these scabs and it could cause a massive amount of hemorrhaging. And I've seen it with blood clots coming out and going into shock from so much bleeding. So, again, no coughing, no gargling, no toothbrushing, all of those things. Keep away from the mouth, let it rest. Analgesics, just acetaminophen is good for this. They used to
So,
have
can I ask a
more.
question? For how
Sure.
long do you have to do without activity? Like without
1 to 2 weeks.
toothbrushing?
1
Okay.
to 2 weeks. Now, the other thing about that toothbrushing is remember, there's blood. It's drying. There's going to be a smell in the mouth. So it is common to have that smell. And I know I was like, oh, go brush your teeth so your mouth don't smell well. We need to at least get up to that week before we even try to do those things. Because again, I've seen them already go to their follow-up visit. A girl all of a sudden started vomiting in the car, got to my triage room, and she was clots. I mean, big liver chunks. And I had to pick her up, rush her in the trauma room, call somebody to help me quick and resuscitate her with some normal saline, a whole liter. This little 7 or 8 year old girl. So it is dangerous, post TNAs, and we send them home. So we need to teach them, keep them medicated. Older kids will tolerate ice on their necks, okay? Younger kids won't. And it does help that ice, okay? Older kids also, there's a lot of swelling and stuff that goes in the back of the throat, and it causes ears to pop, like going up in an airplane. So older kids can chew gum. It's like going up in an airplane and chewing gum. Same concept there, okay? And again, if this, smelling and stuff's going on too long, of course, we're going to call that doctor on it. And, like we were saying, they're not going to be in regular activity for 1 and maybe 2 weeks, depending on exactly how much they did in there. So ammonia can be many things. Ammonia could be inhaling cleaning stuff or caustic smells. I've seen bronchitis is due to going into the bathroom with Clorox and, Comet together and the fumes. I've even had students tell me, oh, I got bronchitis from cleaning my bathroom. And it does, it irritates. Anything that can irritate your lungs can cause a pneumonia. We think of that, right lower lobe pneumonia bacterial, right? But it can be viral. It can be due to an inhaled something. It could be due to feeding and inhaling, regurgitating and getting that aspirating, right? So we do have some vaccines out now, the mycoplasma and the pneumococcal. We give them pretty quick. And there is bacterial and viral. Most of the time we get a pneumonia, most of the time we'll go ahead and treat it as a bacterial. But especially in the younger kids. The aspiration pneumonia, years ago, we used to have baby powder in the NICUs because the smell was so good, right? Of Johnson & Johnson baby powder. And then, of course, research came out and they realized, ooh, that powder in the air wasn't good for their lungs. So we, globally said we shouldn't be using baby powder because of the powder in the air and aspirating it. So that is another way of aspirating things. And of course, we know feeding and burping them well. Do you know what the most common coin that children, usually that toddler, preschooler ages, swallow? It's not a dime, it's not a penny, it's not a nickel, it's a quarter. Always a quarter. And can you imagine? It looks like that. In fact, that's one of my kids. It was right there and it didn't move. So then you say, how do you get that out of there? I had never seen it. I thought they had to go down with bronchoscopy and grab it with tweezers, but that requires going to the OR. That's, starting IVs, anesthesia, waking them up, recovering, and then going home. Well, what we do is down in the emergency room, we'll take this child, sit it on the surgeon's lap with the parents right there holding a hand, and they take the Foley catheter with a big balloon on the end and they insert it down the mouth below where that quarter is. They gag a little bit, blow up the balloon, they lean them forward and pull it quick, and they tell them to cough. And they cough and vomit, and the quarter comes up. I tell them, whoever gets the quarter first gets to keep it. So they're not worried about this. They're worried about getting on the floor and getting the quarter, and I've just distracted them from what happened. And the mother looks at me after it's done and goes, thank you. Because they stopped being afraid. Their focus went on, I'm getting the quarter, it's mine. And I've done that several times. And the trick does work. on children. And that's I've never seen them have to go in and do bronchoscopy or anything. It usually will come out that way. So actually, is it better a bigger coin? Maybe. Another thing kids like to eat is anything in the mouth, beads and paper clips and earring backs. I've seen things in nose and vegetables and peas and red beans and oh, I've seen wasps and ears and all over the place. Now, I've seen a French fry that was inhaled that they couldn't get out, that the child ended up on major life support from a French fry, and it was a 3-year-old. So anything can cause an aspiration in children. Remember, older kids, you're going to do abdominal thrusts and back flaps, right? Remember that. That's part of CPR. What do I do if I swallow a toy? I can't breathe. Abdominal thrust, back thrust, okay? That's what we do. Now pertussis. Now, why do I have pertussis here? We have a vaccine for it. There's been several outbreaks of it where there has been pertussis. And the reason is not everybody gets vaccinated. They don't get immunized. Parents don't believe it for whatever reason, religious, and that's just a fact of life. So I've always learned being a nurse, and I am immunosuppressed. I have rheumatoid arthritis. I do take infusions. So I really needed to be careful my whole career. So whenever I had any suspect of an upper respiratory that I didn't know, and I heard they're not immunized, I'm going to put on my mask first. So you just keep yourself safe. And as you figure out if it is not safe for the other children, then you put them in that reverse flow room. Now, pertussis is a disease that's very infectious. It is bacterial. It does require them to be placed in a reverse flow room, which means the air that's filtered in there filters outside. It doesn't come back through the system and gets refiltered in the hospital, just to make sure that an airborne disease is not carried anywhere else. And it is just IV antibiotics that we start on it. Usually Zithromax is one of the ones we use for this. Smoke inhalation, always remember, I see things like this where I've had hurricanes where they had a stove inside with a fire and the duct broke and the smoke was inside and they came in and now there was smoke injury. And again, it's just monitoring airway, O2 saturations, and hyperoxygenation. I've even seen them go into the chambers where they put them below sea level in them and watch them think up with it. Know that tobacco smoke in children, it affects things like SIDS death, it affects things like ear infections. So it's something that we should not be smoking around children, whether their mom's pregnant or the baby is already born. It does have effects. Cystic fibrosis, another respiratory issue. This is inherited. It comes from mom and dad. And it's a disease where there is mucus plugs. It is multi-system. You think of cystic fibrosis, you think of mucus in the lungs and clogged up, but it also clogs up the small intestines. And it clogs it up and it creates problems with the pancreas and problems with digestion of fat. Okay. So, twofold system here. We've got to work with lungs and we've got to work with nutrition. Okay. So, what would you suspect? Well, if we didn't know and the mother licked their baby and said it tasted salty, it would be a clue. And if we knew that they had cystic fibrosis, you tell the mother to lick their baby, a mother is more like to lick the baby. I'm not, but they might, and they would taste really, really high levels of salt in it. We know because of all of the mucus and extra secretions, it's all in the lungs, as I said. We're going to have to work on lots of ways to get that mucus thinned and keep it moving and keep it coming out. And it's going to be real, and it's not something you do occasionally, it's going to be twice, three, four times a day, depending on the child. Okay. And because you're not digesting fat, you're going to have foul smelling, greasy stools. Makes sense. That's where the fat is. It's all in the stools. Now, why are they have a problem with weight gain? Do you remember nutrition and the calories related to fats, protein, carbohydrates per gram of food? 1 gram of fat is 9 calories. 1 gram of carbohydrates or protein is 4 calories. Do you see how much difference calories are in fat versus protein and carbohydrates? So we need to load these children up with protein and carbohydrates and decrease the fat so they don't have a bunch of greasy stools coming. Okay, so work on the lungs and we got to work on their diet. So we're going to do what we call a sweat test when we're thinking this child has cystic fibrosis. And as I said, it's just little stickers that go on the skin and it measures a number. And it says it's high sodium. That's all it is, basically. How do we treat these children? Well, daily basis is chest CPT, chest aerosols, to keep these chests moving. Daily basis, every food, every snack, you're going to be taking medicines to help digest the fat medicine. So this is a all over the body thing. So for the lungs, as that mucus thickens sometimes, I call it a petri dish, where it's this petri dish ready for bacteria to grow in it. And if we don't keep it moving and thicken, make it thinner and loosen and get rid of it, it's just going to grow, 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 grow. All of these bacteria. So we're going to do antibiotics if we need to. We can give them in the aerosol. And these children are always with a PICC line. Always. Always getting IV antibiotics at home on it. Also, we're going to be doing chest CPT and all sorts of aerosols to keep those chest moving and secretions moving out. Again, we're going to be giving that pancreatic medicines. One of the ones that we use a lot is called pancreatase, and it's capsules or it's a powder. There are certain instructions, and you need to know these. These little beads in these capsules, you can't crush them. It's like an enteric coated thing. So you're going to ruin what they're supposed to do. So never crush or chew those. Now, you can take them, put them into food and swallow them with your food, but not just and chew them down. There's also this powder sometimes we use. The one thing about powder is it can hurt the enamel on the teeth. So when you're done eating, rinse your mouth out to make sure that your teeth are okay. And I think globally, all diagnoses, when it comes to children growing with these diseases, we forget to adjust the dosages according to their normal growth. They're getting taller, gaining weight. It's one thing that we have to really keep up of. I see it a lot in seizure medications, breakthrough seizures, because we haven't increased doses. Same thing with this. We want to make sure this child gets nutrition. Because remember, nutrition gives us our cognition. We're not going to be that alert person that we need to be. So our management, keep the lungs clear, keep those bronchodilators there, keep them open, chest CPT, regular exercise. They say the best, and I'm the one for this, a swimming pool. They hold their breath and they go underneath, and that's such good for their lungs, right? They're going to always aggressively treat pulmonary infections. As I said, they'll put it in the aerosols, tobramycin, gentamicin, right in the aerosol, directly into the lungs. And of course, IV antibiotics, and that's usually PICC lines. Parents get very used to it. So, GI problems, give that pancreatase enzymes, right? High protein, high calorie, and keep that fat level low, or else you're going to greasy stools coming out, right? And again, sometimes they have reflux. We'll take care of that too. But big thing is those pancreatase with snacks and meals at high protein, high calorie carbohydrate. The endocrine problem, you know, The thing with this issue, because it affects the pancreas, in later years, it can cause diabetes. So what do you think we'll be checking with these children just to be sure in daily routine visits? We'll be checking blood glucoses because it could happen earlier. They're all different, right? And again, making sure they're growing, their height and weight is on schedule because they're not getting fat. And that's a big component of growth and gaining weight, okay? Now, as you get older, they've been asked, can women get pregnant? Yes, extremely high risk pregnancy, but they can get pregnant. Men cannot impregnate a woman with cystic fibrosis until they get a bilateral lung transplant. And 1 year after transplant, they can have um, make babies with the mother. Now, I've been asked why. What I have found is there's also sludge and mucus in the vas deferens, and I think it clogs up the duct so that they can't give the woman the sperm. I think that's what happens, but it's actually very unclear, but that's what your book says and the literature says 1 year after bilateral lung transplant. Sleep apnea is just like adults. Kids, snore. Usually what they do is they do a tonsil and adenoidectomy first, right? But again, we can make sure a child sleeps well. They might need that CPAP machine, just like adults, right? Do the sleep study, put them on the machine, and we can get them proper rest. And without proper rest, children are cranky. Adults are cranky without it. Acute respiratory distress syndrome. This is some lung injury. Could be smoke injury, could be hypoxemia due to drowning. It could be anything that the lungs have really, really been hurt. Overwhelming sepsis. What about crushing chest injury? This is your sickest kid because this is your airway. And sometimes we don't see it initially. For instance, you're drowning. This kid can be up and running around and looking like nothing happened when you get them to the emergency room, but they were just underwater and they were, you know, 20 minutes ago. That child will be admitted because the injury has up to 72 hours to show itself. And then all of a sudden they go down and they can't breathe. Again, ARDS is a big thing. Body can't breathe for themselves. There's all different things that we can do. This machine right here is something that I actually got certified on. It's called ECMO, and this is the newborn. They can't breathe usually due to meconium aspiration or other stuff, right? So you take blood out, put oxygen in it, put it back in. It's not heart lung. It's only working as oxygenation as a lung. But you can see how sick that child is. Remember with CPR, you're going to see questions on the exam. Is it 15 to 2? Is it 30 to 2? What do you do for choking? Remember, abdominal thrusts. Those are the couple types of questions you will see. Also, remember, behind that CPR and that child is somebody worried. Always make sure somebody's with them. Many times, years ago, we threw them out of the room and closed the door. We don't do that anymore. We, as much as possible, try to keep that parent with their child. What if that's the last time, right? And it can be. So again, have somebody with them with updates. Now, anybody here have asthma? I know asthma, yeah, it's a big thing. My husband went to status asthmaticus on me. He was in the ICU for 12 days, could not breathe. And he only would breathe because of me, or else he would have been intubated. So, yeah, I've had a really, really good experience with it. So, what is asthma? So, remember, crew, upper airway swells, I can't get air in. Asthma's different. All of this is open. The lungs are irritated and swell. So air goes in, it can't get out. So it's like the expiratory trying to push it out. Expiratory wheezing. That's what you need to remember. Stridor in is croup, epiglottitis. Asthma, expiratory. I can't get it out. Prolonged expiratory phase, okay? And it's usually due to some sort of allergen or something hits their lung, swells up, and they can't breathe. So what do? Right? So you have a child who now is on that little inhaler, that rescue, that little albuterol, Ventolin, Proventil, whatever your name is, and they have to take it for rescue. It can be normal, but if a child is allergic to grass, you wouldn't be have them out there playing something with grass. You'd have them swimming or bowling or maybe tennis on a tennis court, right? Something that wasn't in grass. So we can work with it, and as long as they have their inhalers and they're doing their treatment, we're doing okay. I mean, checking for allergens. What are they allergic for? Trying to desensitize them. We do all of those things with kids so that we can stop these asthma attacks from happening. I mean, did you see these little things in the bottom left? Those are little spacers. Now, adults, along with kids, don't know how to take a deep breath, push the button at the same time. And it's a great thing. You put it around their face and push one, two times, whatever it is. The kid's going to cry because they don't like it, but they take deep breaths in and out and they get the medicine really deep and they get that, albuterol where it needs to be. So children now find out that they're these chronic kids. They start using their stuff by themselves after a while. They know, go get your stuff, give yourself, let me support it for you. And they do it. Know that there are just like adults. We have the one that has a little steroid in it. In adults, it's something called Symbicort, Advair, Brio, those things. Little bit of steroid in it. In children, the one we use is called Pulmicort, and that's morning and night, preventative. And then the albuterol is for rescue. Those are some things you learn in pharmacology. It's just a refresh. When we get them on a good routine, these children have less outbursts. Status asthmaticus, like I said with my husband, I'm telling you, I've never seen the fear like I've seen in this. It's their feel for some reason because they're so swollen, they cannot breathe. Air will go in, they can't push it out, and it becomes overwhelming fear. And heart rate goes up, blood pressure goes up, respiratory rate goes up, and it is something that you have to break. And we break it with rescue inhalers or aerosols, albuterol. Sometimes we have to do the level of albuterol where it doesn't affect the heart as much. So there's rescue stuff, and then we go into other treatments. Aminophylline drips is one of them, and of course the Solumedrol, the steroids that all go along. And I think the biggest thing that helped him was my calm, and I would sit there, hold his hands, and say, "Okay, it's all right," and I would talk him down. It was getting that child, and I've talked children down, I've talked friends down, having attacks without their rescue. It's relaxing them, number one, getting them calm. That child wants to be in mommy or daddy's lap. Oh, put it in it right away. Yes, put the mother in bed with them. I don't care what you do. Calm the child down. Calm the adult down. That's how you improve status asthmaticus. We all know about COVID. We know there's no cure, but again, there's immunizations and it just being safe. So, hearts now. Now, hearts is probably a little confusing. So, I've been sitting here thinking about how can I introduce it in a manner that's not so overwhelming. So, there's two types of hearts. There's one that gets enough oxygen, and there's one that, for some structure, is not getting oxygen. And that's called a cyanotic heart disease. And that means it's not going to the lungs or not coming back from the lungs. Something's happening. It's not completing that whole path of that drop of blood. Okay. So, hearts. Now, with children, it's usually congenital heart defects that we see. When we talk about acquired, those are usually your cardiomyopathies due to viral illnesses or autoimmune lupus type things. But many of the congenital heart defects are at birth, right? Born with them, congenital. And if it's a defect that doesn't give oxygen to the body, you've got to do something. So let's look at a drop of blood. This picture is in your book, and I need you to refresh because knowing what valve, what chamber things goes through is going to give you a lot of names, a lot of different diagnoses that has to do with hearts. So let's talk about how the blood comes into the right side of the heart. So through the inferior superior vena cava, blood, after it's gone all the way everywhere, very slowly drips back in to the right side of the heart. So the right side is lower pressure. It just gets back from a heartbeat. Goes through the right atrium. It goes through the tricuspid valve into the right ventricle. Goes up through the pulmonary valve into the lungs. It gets all that oxygen. It goes back to that left atrium, goes through the mitral valve into the left ventricle, and then that pump takes over and pumps it through the mitral valve up the aortic arch in the aorta to the body everywhere. Those little three red ones on top goes to the upper body. And then the arch coming down, it starts giving the liver and the kidneys and everything, blood all the way down to the feet. Now, what happens if there's a kink in the hose? Think about what happens in your garden hose. If you kink it, after the kink, there's no water, right? If the hose is on. But before it, that water, that blood, that hose, it's got to go somewhere. So it's going to find areas of least resistance, or it's going to keep, getting bigger and bigger. With the body, it'll find areas of least resistance. So let's put this on you. As the blood comes out of the aorta and goes down the aortic arch into the body, there's a kink. There's a kink. Blood only a little bit can go down into all the body's organs and down to the feet. So now, what would you expect with pulses in the feet? They're going to be non-existent, or they're going to be really, really minimal as comparative to the upper ones because the blood's going up, it's not going down. So I don't feel pulses in my pedal pulses, my dorsalis pedis, my posterior tibial. I don't feel pulses. I go down to the femoral. I'm barely feeling pulses. Something's going on. How am I going and what am I going to do next? I'm going to take a four extremity blood pressure and I'm going to show that the pressure is up with all the blood and not down. The upper extremities are going to be at least 20 points higher. And the lower extremities are going to be 20 points lower. That's telling me it's something called a coarctation of the aorta. It's one of the diagnoses you will see around. So it's a kink in the hose. So if the blood can't go down, it's going up. What would you see in older kids? Well, maybe all of a sudden you're looking that looks like they have high blood pressure and they start with nosebleeds and headaches because all the pressure is going up, it's not going down. That's an older child. A younger child, hopefully we would see that there was no pulses in the feet. In my career, I found one. I found one of these coarctations before the doctors did. It's like, yes, I caught it. But it was again doing the assessment, checking pulses for extremities. You always do that on newborns. So when you're looking at a diagnosis, think about the heart, think about where blood needs to go if something is blocked or not open or narrowed. Right? So this this example of coarctation of the aorta reminds me of a little girl, and it's everything we're going to talk about now is everything she came into us with. This girl was almost 3 months old. She lived on the west coast of Florida where they didn't have as many cardiac people who understood cardiac because pediatric cardiology is extremely specific. It is not adults, it's different. It's more congenital heart defects that we're talking about. So finally, she got over to us about 3 months old, and she was not eating well. She was tachypnic. She was tachycardic. Her weight was well below where she should have been. She had absolutely no activity intolerance. And of course, she was barely even trying to hold her head up. She should have been holding it up by then. And diagnosis, coarctation of the aorta. So, why do you think, and this is a great nursing diagnosis, child coarctation is working against now? This blood has now been kinked. It's gone all the way to the upper extremities. It's gone back into the left ventricle, up the left atrium, and the lungs are filling up with fluid because it can't go down to the body. It's going backwards, backwards, backwards. So the lungs are filling up. Can you see why this child is in severe respiratory distress and hypoxic? Her lungs are full now with fluid. So inadequate oxygen perfusion, leading to activity intolerance, resulting in diminished energy to feed, whether breast or bottle, because they're just struggling to breathe right now because of all this extra in the lungs. So cardiac kids, when we look at them, number one, you can tell sometimes just by looking, just a visual observation. I mean, in infants, you can see chest retractions, you can look at colors. I can put my hand and touch a child's chest. You can feel murmurs vibrating on your fingers. It is a different thing. Now, this clubbing of fingers, that doesn't happen till later, but I got a picture of them for you. But we know a kid, if they're looking blue or pink at birth, I mean, there's, yes, many babies at birth have the blue hands and the blue feet. It's all part of the normal, but it continues. And then you would see the other things with it, the tachypnea and the tachycardia and that. These children, when we look up and put them to a monitor, and of course, they're going to be tachypnic and tachycardic, and their O2 sats may not be normal. So again, it's when do we put oxygen, when we don't, and that's another conversation that just know that sometimes we do and sometimes we don't, depending. We're going to be looking at the heart rate. We're going to look at the rhythm. And of course, listening to those heart sounds. Is there murmurs going on in there? Sometimes it's, and that's a big VSD in there. I mean, you can hear how big that murmur is in that child. So you get a kid in, they're suspecting cardiac. We think it might be coarctation. Next thing, absolutely, they're going to do is a cardiac catheterization. Parents get a little bit freaked out with this, but this is giving the absolute perfect information the surgeon needs in order to do whatever procedure needs to be done. Because, the best thing about kids, why I like it so much, no two are the same. Keep me thinking because it's not like adults. There's always differences in every child, even same diagnosis, everything the same, they're different, which I love. It keeps me on my toes. So, cardiac cath, you send them off. One of the things to know is we don't keep them NPO for a long time prior to procedure, especially the really small children. We can't. Their blood sugars are dropped too quick. I believe newborns, breast milk can be given up to 2 hours prior to procedure, just for you to know, because of glucose. So you get this child went to the OR for the cardiac cath, comes back. Remember, they have to take the child off, put it on their cardiac cath table, do what they need to do. There's big sheaths in the right femoral artery and vein. So they're holding pressure there because it'll bleed a lot, okay? You have to put big, tight dressings on there to hold it, pressure dressings. And then they're putting this kid back on the table and bringing him down the hall, and it's jostling, and things could bump, and it could move the clot that's on that right femoral artery or vein. So, guess what I'm checking first? Number one thing I look at, I'm looking at that dressing because I'm scared because that could bleed out so quickly. Can you imagine an artery and a vein are one of the biggest veins in the child's body? And if that clot comes, that bleeding out can happen quickly. So check the pressure dressing. If it is bleeding, you're going to put your fingers above it, closer to the heart, and you'll call for help. Okay. And it's pressure. It stops the bleeding. And then the doctor can decide, do we need to do a CBC? Do we need to give blood? Do we need whatever? But again, if you just put pressure there. When they come out of this procedure, they must keep their right leg flat and straight to prevent the clot from moving. And they will be on bed rest for 24 hours. Older people too. Again, to prevent the blood clot from coming off and the bleeding going on. Now, that extremity usually has like slighter, less pulses, only because of the intrusion of those catheters that were put in there. But just document, let the next nurse what's going on. You're going to check, of course, pulses, and the temperature. You're going to take your vital signs. And we will be checking blood glucoses. Number one, is it too low or too high? Do they give glucose up there that you don't know about? Then the glucose is too high. We need to change our fluids. Or did they forget to give this baby some glucose and now your blood glucose is 30, which I've seen that too. So again, checking it. And if they're awake and alert, fluids, IV, PO is fine. But again, bed rest 24
Mhm.
hours, just elevate the head of their beds very little. But the biggest, again, risk is that hemorrhage from that catheter site. And again, just put pressure. So, how often does congenital heart diseases happen? More often than you really know, more than I knew before I started working in this area. It is the major cause of death in the first year of life after prematurity. You know, that might even be revisited because they're doing so many advances in it. The most common of all of them is the hole between the ventricles called a ventricular septal defect. And the child that is most apt to have that is a Down's child. And then you're looking at there's different numbers 21, 13, 18. Downs do have different numbers. I've actually seen a 9, and it's the most severe of all of them. More things that went on with them. I want you to remember Down's children have multiple things you need to check them for. This is an area you need to know this concept, okay? Down's children, congenital heart defects. First of all, is one of the big things that you are concerned about. Leukemia is another, and hypothyroidism. We'll keep going, but again, poor little Down's children, we would be really careful on looking, and we might even just do an echo just because they're Downs, just to make sure we're not missing anything. So, congenital heart defects. There again is a bunch of pressure going on. Remember, just like the ears, where all the mucus went there for otitis media, because it's least pressure. In the heart, there's areas of least pressure, like the coarctation, the least pressure was in the lungs, and that's where the fluid could build up. There was room, it was space, right? So, looking at pressures of the heart. Remember, I said the right side of the heart had just a little pressure? The blood just got back, right? Now, the left side, do you know there's 4 pulmonary veins? I always thought there was 1. There's 4. All that flow is going into the left side. So if there was a hole between the top sections, there would be some shunting from the left to the right side. Do you see that? What is a baby born with? the patent foraminal valley, a hole between the two atrium, the right and the left side. If I have high pressure on the left, pushing pressure down, some of it's going to go back to the right side. And what's that going to do? It's just going to cause reoxygenation of the same blood. It's okay. It happens. So think about shunting and where would be the easiest or least resistant. It's always going to go left to right if there's an opening, because the right side is low pressure, left side is higher. All right, let's look some of the defects. I've told you there's acyanotic, which means they're oxygenated, which is great. And then we have cyanotic, which means we have to find a way to get oxygen to this child, or else no oxygen, child's not going to make it. So acyanotic is any hole in that middle partition called a septum. You have atrial septal defect between the two atriums and ventricular septal defect between the two ventricles. Any sort of hole there is just going to increase the flow into the pulmonary flow because of that shunting, right? From the left to the right, it's just going to reflow it. Not a big deal. Now, one of these particular little things that you need to know, and it's about fetal circulation, it's called a patent ductus arteriosus. You know, interutero, the baby connects the lungs and the body with a tube called a ductus arteriosus. Patent means it's open. After birth, mommy's not making this prostaglandin that keeps this open, this hormone, and it closes. So the baby just breathes normally with a normal heart. That's great. Well, what if the baby doesn't oxygenate? There's no connection. One of them, the big one, transposition of the great arteries. You have the pulmonary blood flow going around and the systemic, and they're not meeting because those two great vessels are interchanged. There's no oxygen. How do I keep oxygen on a child who needs it? I need to keep that patent ductus arteriosus open, or else I'll just shrivel up and go away. That's what they normally do. And I can give something called prostaglandins, a synthetically made one, and keep it open and keep oxygen going. I know it's a lot of information. All right, obstruction of the blood flow, the coarctation of the aorta. Remember, I can't. Where does blood flow? Goes backwards. Where does it sit? Goes up into the lungs. What am I going to see? A child with difficulty of breathing and no pulses in the lower extremity. Find a child with no pulses in the lower extremity. What am I going to do? I'm going to take a four extremity blood pressure. I want to see if there's differences. I want to rule out coarctation myself, because usually it is the nurse who finds these first. Now, when you see stenosis, that word, it's only a narrowing. That means blood is still going through, but at a smaller rate than it should. Aortic stenosis is the left side, right? Going to the body. It's narrowed. Pulmonic stenosis, it's a narrowing of blood going into the lungs, right? So it's narrowed, decreased flow. When you see atresia, A means without, that means nothing. So a tricuspid atresia means the tricuspid valve is not open. So what does that mean? Where is tricuspid valve? It's on the right side between the right atrium and right ventricle. There's no connection. Again, there's no blood going to the lungs. Guess what I got to do to keep this child alive? I got to keep that ductus open again, don't I? I need to give a slow, continuous infusions of prostaglandins. Now, the one big test that your HESI and your NCLEX loves to test you on. The big one is tetralogy of Fallot. Anybody ever hear of something called a tet spell? It's when babies turn blue all of a sudden for no reason. They turn blue. Well, what happens is something happens with the pulmonary artery. Remember, in the right ventricle, blood goes into the lungs and it has to go through that pulmonary artery. Something happens, it kinks, or flap goes over it, and all of a sudden, no blood goes into the lungs. I've actually had this happen to me one time, 5 o'clock in the morning. This little 1 month old baby's name was Nolan. I'll never forget him. And he had a tet spell on me. He went from an O2 saturation of 100 to 10 in about a minute. And what did I have to do? The treatment for this initial knee to chest immediately. So whether you're sitting, an older kid squatting down, or you as a nurse take the knee to chest, whether this way, anyway, knee to chest. And what that does, it changes the pressure in the abdominal cavity and the chest cavity, and it pops open this, what's ever going on, preventing blood from flowing. And that usually works, okay? Tetralogy of Fallot, tet spells. Older kids will all of a sudden squat on their legs. And I don't know why they do it. They do it. Most kids are usually, fixed earlier as infants so that we don't have these tet spells. And then the mixed blood flow is again, it's that transposition. And I'm just going to mention it is hypoplastic left heart syndrome, the most severe of all of the cardiac conditions. The left ventricle, your pump, is non-existent. There's no muscle, blood can't get around. It is a minimum of a 3-stage surgery, and many of those children end up with transplants. Okay, just so that you know, hypoplastic left heart, HLHS. So let's go look at this ductus. Excuse me. Again, a PDA, we need this in mommy open for fetal circulation. After birth, most close within the first 21 days because mommy produces something called a prostaglandin. It's a hormone. And it's a continuous infusion. Mommy gives it. Well, at birth, mommy's gone. So usually it'll just close up by itself. Now, what would you know or see if it was open? And I think this is pretty neat to listen to. There's this loud washing machine murmur. It's like a washer machine. And you can hear it. It's that valve that's open. Now, many of these children that have this PDA open usually are premature or cardiac, and we have them on central monitoring, like they'll have an umbilical artery catheter blood pressure going, which is pretty neat. So it's a constant blood pressure. Now, pressures for a newborn, a neonate, is 60 over 40. With a child that has a PDA, look at that bottom number, the diastolic. It's really, really far. It's called a wide pulse pressure. Now, why do I mention that? Well, many times we have to medically close this because the body, I don't know, just had some prostaglandins in there and it keeps open, but we want it to close because of too much blood flow going on there. So we give this indomethacin and it closes, and we can watch that blood pressure number come up. We can stop that murmur stops, and you can listen to it all happening. And I like to watch the blood pressure go up. By the end of my shift, it went from 62 over 16, and now it's 60 over 32. It's like you watch it come up, you watch it closing. So again, the PDA gives oxygen. It's normally closed by the body, but we can give that prostaglandins. Now, what is the goal of prostaglandins? Well, the prostaglandin, number one, keeps oxygen. So it's oxygen saturation. But because it's open, now it's also cardiac output. We can get good cardiac output and given good cardiac saturations level. Know that the medical closure of a PDA is indomethacin. And believe it or not, that's an NSAID. It's an old-fashioned one that we used to use for back pain, like, I don't know, back in the 80s and 90s. I remember hearing indomethacin. But it is an NSAID, it's IV, and it's given to 3 doses. And again, you can hear the murmur close, and you watch that pulse pressure come back to normal. So, increased pulmonary blood flow. Any hole between the right and left side, it's going to go from the left to the right side back into the lungs. An atrial septal defect, ventricular septal defect. Look at that PDA. You've got blood going from the aorta back to the pulmonary artery. That's where they're connected. Aorta to pulmonary artery. That's where fetal circulation is. And there's just some more pictures for you. Now, congestive heart failure. You had the kid, coarctation. Now, all the blood's gone into the hearts. It's filled up with blood and fluid. Now you're in congestive heart failure. What's going on here? Well, that heart's beat so hard, so long, it's getting tired. And it's getting tired, so it's not squeezing everything the way it should. So blood is going back up into the lungs and filling and filling and filling. You're going to see a chest x-ray full of fluid. I mean, that's how severe it goes. So what do we want? Well, we want the heart to beat more effectively. We want to get rid of all that fluid. So the kid can breathe easier, eat better, less cardiac demands, and we can get oxygen around to the body. So what do we need to do? Well, we need to get rid of that fluid. We're going to be giving things like digoxin and furosemide. And how do we know all these things are working? Remember congestive heart failure in 2 different ways. You're going into congestive heart failure when you see an increase in daily weights of a big amount of weight. Or your congestive heart failure is getting better when you're seeing a good decrease in the weight on the daily weights because now you're losing all the fluid. So again, daily weights, congestive heart failure, hand in hand, you can see what's going on. Remember, if we use digoxin, follow the rules. It's something we learned in pharmacology, right? Same thing adults, same thing as children. Count it for a minute. Look at the electrolytes. Potassium's low. Don't give it or you're going to go into digitoxicity, right? And if you have a digoxin level, check it. Now, with adults, they're going to tell you they see yellow spots, or they're going to tell you they're nauseous, or they vomited. Now, is an infant going to tell you that? You might see that kid vomited, maybe just once. If a kid's on digoxin vomited once, and that's not normal for that child, guess what? I'm going to hold the dose. I'm going to call the doctor, and I'm going to get either approval to give it or to draw another digoxin level or potassium level. I want to be sure I'm safe with digoxin, right? What does digoxin do? It gets rid of all that extra fluid. It decreases the load on the heart, and because we're breathing better, we're eating better, the fluid is gone. And again, we need to be teaching what we're doing, why we're doing it to the parents, and why that child's looking better or looking worse when they're gaining weight or losing weight, looking better. Hypoxemia we have, for instance, that hypoplastic left heart syndrome at birth, a normal O2 saturation could be 65%. And you wouldn't put oxygen on them for many reasons. Yes, it's like, really? Yes, that 65 is actually acceptable. Usually after the first stage surgery, we want it about 85. We can. And hopefully by third stage surgery, it goes to 90%. If it's above that, we're doing even better, okay? That would be a hand of an older child with a hypoplastic heart or somebody with a congenital heart defect. You see the clubbing of the fingers? That's what you would see. What else do we see with these children with like that hypoplastic left heart? a child that's, body is trying to have oxygen and just not getting enough. And the body is really, really putting out effort. Well, what the body does, it produces red blood cells. What do red blood cells carry? Carries oxygen and iron to the body. So if your O2 saturations aren't normal, what's the body doing? It's producing red blood cells because they think maybe if I produce red blood cells, there'll be more oxygen and I can breathe easier, but it's not going to happen. But that's called polycythemia. When the body thinks it needs to produce more cells because it doesn't have the oxygen, that's what causes polycythemia. This child's hemoglobin hematocrit, it's normal, 18 and 54. What's a normal one for a congenital heart with, hypoxemia, cyanotic heart disease? Okay. Again, you would be surprised. We call cardiac families, heart babies, some of the most amazing families. Again, it's the teaching. And, in cardiac, when we work at, even if your child's getting ready for discharge, does not mean that child's out of, trouble. We teach our families everything. Let them know what to look for, what to watch out for, what to do if they see, how to do medicines, count heart rates, check for, dehydration, listen to lungs. We do all of those things because number one, they're your second eyes and ears in a hospital. And number two, many of these have a long road of recovery, and it could be a continuous one for especially hypoplastic left heart. Okay. And these children, tend to be the smart ones. And again, they teach me things in the end. I've already gone over cardiac cath. That's another one on it. Bacterial endocarditis. Any sort of infection, again, this is something that we're going to be given prophylaxis. Again, if we diagnose this, again, it's IV, immediate high dose antibiotics. Most likely, if they're going to go home, PICC line with it. Now, there are two diagnoses that can happen due to a strep throat that was not treated completely. Whether it was, they said, viral, it wasn't given antibiotics, or the antibiotics didn't complete the treatment, but there was still strep left in the body. Strep can cause something called rheumatic fever. You're going to see a sore throat, swollen glands, joints. You're going to be seeing a rash. It gets to the point sometimes where they get this chorea or these weird movements that the family goes, something's wrong with my kid. And then they get into the hospital. The first question is, has your child been sick lately? They've had a sore throat in the last month, they're going to be doing something called an ASO titer, an anti-streptolysin titer. Hear that strep in the middle? It checks if there's strep in the body. And if it's positive strep. Now, all of those things I mentioned will all go away with treatment of high dose antibiotic, except if rheumatic fever is left to go on too long, it will attack the mitral valve and cause permanent valve damage. And treatment will take care of all these weird movements and rashes and sore throats and glands, but it will not take care of that heart. That's going to have to be medically or surgically treated. Kids can get high cholesterol, something we're doing earlier. We didn't test kids earlier for cholesterol, and some kids do have it earlier, and we treat it with diet. Cardiac dysrhythmias, slow, fast, and irregular. Just like adults, we can have all of them. I've actually seen pacemakers in kids less than 2 years old. I mean, they're about this big, they're tiny little things, but yep, we use them. Pulmonary artery hypertension. A lot of times we think about this with your premature children that have been on a lot of oxygen and their lungs are damaged and they're so stiff and that exchange of oxygen can't happen. Basically, these children are oxygen deprived. Any activity will cause chest, pain and discomfort and shortness of breath because they can't get the air in there because it's so tense and so damaged, all of the alveoli in there. Cardiomyopathy, like I told you, this is one of the big ones that can lead to children requiring a transplant. And this is usually later. This is not at birth. This is usually later on we see. And as I said, it could be viral, it could be lupus, could be some sort of metabolic something that happened, but it can. If after treating it and trying to tune it up, and we would do it as many times as we needed, we would definitely, suggest that heart transplant. Know that rejection is the largest reason for death. Now, cardiac kids. One of the things all the kids get, you open a chest, you're going to have a chest tube. Now, older kids, again, how are we going to take these out? Now, if you've ever worked in the adult world, which I have, in the open heart unit, which I have, and I worked night shift where they took out all the chest tubes at 6 a.m. It's just what they did. When you talk to adults, it burns. It burns intense. And it's for a short period of time, and then it goes away. Okay, according to adults. So, with a child, number one, take a set of vital signs, any baseline. Make sure you medicate them for pain. It hurts, it burns. And then let them know what they're going to do and be honest. It's going to hurt a little bit, but I'll do everything I can to make it hurt as little as possible. And it will just for a little while. I'll hold your hand. Let's count together. And then, of course, do a set of vital signs when you're done and the child's calm because narcotics can affect blood pressure. High blood pressures, children, it does again happen. We're actually testing earlier than ever. We never tested below 5 years old, and now we're testing everyone. You have blood pressure on every child coming in because we have found hypertension. And what does it cause? We know in adults, disease, right? That's a big one. Now, Kawasaki disease. This is a disease. It's again a systemic vascularitis from unknown cause. We think it's a viral thing. So it's not an antibiotic treatment here. Okay. This is a systemic inflammation of vessels. Our concern is the coronary arteries because they'll get inflamed and they'll get little aneurysms and those will burst. And that will be the end, a coronary artery bursting. Okay. So, what do we see with these children? I mean, you got a bunch of little pictures here that's showing you stuff. These are the children that have been sick. Fever 101, 102. They have a rash. Their lips are red, tongues are strawberries. Their eyes are glow in the dark red, like red. Never seen eyes this bright in my life. So, though the hands, sometimes they'll be flaky, blistery, peeling. The palms and the soles of the feet also. What we'll do, and usually we have to call infectious disease down to get the final diagnosis. Sometimes these are really tricky. They're very fine little things to look for. But the treatment is let's boost their immune system with IV gamma globulins and high dose aspirin. This is the only time you give aspirin to children. And why aspirin? It's vascularitis. There's little mini blood clots that could be there, right? It thins the blood and it prevents blood clots. And also, isn't aspirin an NSAID that could help with if there was any discomfort? It's going to help with a fever. I know that. It's an aspirin, right? Sometimes they don't use aspirin and they use an anticoagulant like Coumadin. But most of the time, it's IVIG and high dose aspirin on the younger kids, especially. We've already basically talked about COVID, shock. Children in shock, the most common is septic shock. Children have no immune system, especially the young ones. You start seeing little symptoms, and it's apneas and bradycardias. It's as simple as it is. They're starting to show you their body's not happy. Um, that's going to be a septic shock. What happens when you see shock? What would be vital signs? Elevated heart rate, decreased blood pressure, prolonged capillary refill, decreased urinary output. Think about it, shock. The body goes, I'm done, right? Same thing, adults, children, shock is shock is shock. Anaphylaxis. Well, that can happen due to many things. Give Christian a good old walnut, he'll go into it pretty quickly. And it's all of a sudden the face, everything blows up and, you know, closes off and you can't breathe. How do you treat it? Well, number one, keep away from it, which he knows now. Does it have nuts in it? It's the first thing he asks if anybody gives him food, because he's afraid of it. Again, it's giving them the epi. Septic shock, again, is just knowing it, looking for the signs. Toxic shock in the adolescent, tampon use, just for them to be aware of it, right? And then, question, think about this. Surgical closure of the patent ductus arteriosus would result in which of the following? PDA. This is that fetal circulation. It connects the aorta to the pulmonary artery so we can get oxygen to the body. So if we cut that off, what's not going to happen? Prevent the return of oxygenated blood to the lungs. So a lot of stuff. And I know cardiac's pretty hard. If you can go ahead and look at that, the handout that I gave you, that matching sheet, all of the important names and concepts are there. If you're having a trouble following that, let me know and I will help you. But you got to ask. Okay, let's do this. Who wants to win today? So tell me, is it going to be the Bogart class or the Luminosa class? Come on, guy. Let's make it a fight. Season, don't fight. Friendly fighting, right? No, this is probably of all of the lectures, probably the longest one because it's just so much stuff in here. So if there's anybody who's having a problem with it, I don't care if you're in Professor Luminoso's class, just message. I can meet with one of you or a group of you, it does not matter. So if you don't know how to do it, take your camera and point it at the UPC code and it will send you straight there, or go to kahoot.it and there's your game pit in code number. Oh, we have a Lucille ball. I like that. Ricky, oh. So week 5, respiratory cardiac. A majority of upper respiratory infections are caused by what? Viruses. We go to the doctor. We're so upset because they have a fever and they send us home with nothing. But actually, high fevers are usually viruses. Believe it or not, in my experience, 101 to 102, that's usually your bacterial infections. Believe it or not, it's what I found. Multi. Down's children are more susceptible to which medical conditions? I mentioned it. This is one thing I've seen on the HESI. Seen it on several exams, several quizzes. It's one of those things, those poor Downs children, they're the sweetest children, and they're out to get everything here except diabetes, all right? But hypothyroidism, congenital heart defects, leukemia, that's why they do ultrasounds and check them and do blood works and, follow up with those CBCs and thyroid levels. They have to. You walk into a 6-year-old's room and you find them not breathing and does not wake up. What do you do? Again, I think you saw last exam there was a CPR question. You're going to see more. That's why I'm telling you. Look at it. So, what do you do? An unwitnessed arrest, right? You walk in, you start CPR. That's number one. Chest compressions. Same time I'm popping the button above the head, it's saying code, course, right? And then it's 30 to 2 till somebody comes, and then it's 15 to 2. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Just say have a fever. I mean, children that are sick have a fever. What are they going to look like? Sitting in the corner, quiet. They're going to have a fever. They're not going to eat. They might be vomiting and their tummy might hurt. It might be all of the above. That is usually the signs my kid's not feeling well. One of those four commonest things I hear. A multi. What do you look for when assessing respiratory function? See, I can look and see so much in children. We have this thing, well appearing and sick appearing. And you could look at a kid and know, hey, it don't look good. It's breathing fast, it's breathing hard, and it's very shallow, and you can hear him grunting. I mean, all of these things you can hear and see that easily. Very good. What would you look for after a child has a tonsillectomy? So you have a kid who's got these big scabs in the back of their throat. Think about it like that. Our biggest concern is those scabs coming off and bleeding, so you don't have to resus that child like I had to in the trauma room with a liter of normal saline. If they're swallowing, they're bleeding. So pain is normal, okay? It should be severe. I've had a tonsillectomy later on in life. It hurts, but it's not horrible. And Tylenol actually works, and it works well. What we're concerned about is the bleeding. So it's all about swallowing. They're swallowing, they're probably swallowing because there's blood back there, but they don't know to tell you that because their mouth tastes like blood anyway after surgery. A multi. Nursing care for a child status post-tonsillectomy include Ah. So we don't want to give spicy foods. That's very bland foods. We don't want like citrus or anything hot peppery thing. No. The pain medicine is needed, being around the clock. Don't get behind so that you can't get in front of the pain. Gum, remember, for their ears, especially older children, because their eustachian tubes are blocked. And older kids, again, like the ice there. It really is a comfort. A multi. Would you suspect if a child has a dry, bothersome cough that keeps them awake at night? What's that called? That is bronchitis. And the other name is called tracheobronchitis. It's the same thing. The trachea and the bronchus aren't inflamed, and it's this dry, hacking, bothersome cough, and you can't sleep. And your chest hurts from coughing so much. A multi. What signs and symptoms would you see in a child with otitis media? So usually otitis media, they don't have fevers. That's the one thing. What they're going to complain out is the ear pain. And with pain, children just won't eat. It's just part of them. If you see the purulent ear drainage, it means that ear is already burst, okay? But definitely ear pain, and they'll you can touch it and hold it. And you try to give them a warm pack or a cold pack, and some of them don't even want to touch it. Give them some ibuprofen. 20 minutes later, and the world is lovely, and then you want a popsicle. It's that ibuprofen, fever down, pain away, and they're going to start having the liquids, which are what you want. The monthly immunization for RSV, what is it called? Yeah, there are a couple names of medications you need to remember from this week. The one from this there is Synagist or Pavizumab, which is a biologic once a month for children at high risk for RSV. Hib is for hepatitis. Humira is given for rheumatoid arthritis. And Indocin or indomethacin is to close the PDA, okay? Prostaglandins keeps it open. A 4-year-old's been taking the meds for asthma and they're still wheezing. What information is important to know? What's going on that you need to know about this kid? They've been taking medicine for asthma, but they're wheezing. What do you need to know about? Well, what medicine is it? Are they taking the right medicine? And then sometimes, again, it's just taking the medicine inappropriately, putting it on a spacer, make sure that they get all their medicine. And that's adults or children. It's just easier to squirt it in there and breathe in and out several times. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? So remember, croup is all upper airway and has to do with air going in. And we'll just treat it with some steroids. That's all we treat it with. So again, you can't get air in, you're going to see that respiratory distress. What do you see with respiratory distress? Retractions and restlessness. Signs and symptoms of asthma include all except what is not asthma here? So the problem with asthma, you have cough, you have wheezing, you have shortness of breath, but remember, air gets stuck in. Remember that inside gets all inflamed. This here, the upper airway is fine. I can get airway in, but it gets trapped. And then it's swollen and I can't get it out. So it's prolonged, like trying to get that air out. And you're lucky if you hear a squeak sometimes. It's that little bit of air moving. Signs and symptoms of congenital heart disease include all except. So remember with congenital heart disease, something's not right. The heart is not, built normally, and it's actually working a lot extra, right? To be able to pump around. That's how you have to think about a congenital heart disease. What are you going to see if heart's not beating right, oxygen's not going around as much? You're going to be poor feeding. You're going to be tachycardic. You're going to tire easily. Absolutely. And you're going to be burning calories like crazy because you can't eat and you're burning them. So your weight's going to be below normal. What should you do not do to children diagnosed with croup and epiglottitis or post-tonsillectomy? So you don't want to do anything with the mouth. You don't want to look in there. You don't want to create any extra swelling that's going on, like putting tongue depressors and stuff. No, you would not do that. A multi. Treatment for infectious mononucleosis. Remember, it's just a kissing disease, right? Remember, it's an Epstein-Barr type virus. So it's a viral condition, and our biggest concern is swollen glands, especially, the spleen or the liver. So rest, no contact sports because you don't want it to burst like that little boy. And of course, that low-grade fevers, aches and pains, antipyretics. Again, it's a virus, so you don't need antibiotics. A multi. When doing an admission on an infant that has a low-grade fever and a loose cough, for more information is important. You're doing an admission. Where are you going to put this kid? So when you are admitting any child, you need to admit child that they're safe to be with each other. And some of those is immunization status. If they've had immunizations together, we're all right. Plus, with this child, you need to know, where are the fevers? What are the numbers? And of course, any medications, acetaminophen, ibuprofen, you need to know when to continue or follow it. Or if they were on antibiotics at home, when was the doses, etc. What is the greatest risk for an infant having a cardiac catheterization? So the biggest thing with cardiac cath is they have to thread two catheters in the right femoral artery and femoral vein. And the biggest thing is them bleeding out from it. Again, what's the first thing I'm checking when they come back to the room? I'm checking the groin. I'm making sure that dressing is dry and they're not bleeding and that pressure dressing is intact. Is cystic fibrosis identified? It's the test we use. It's number one. There's so many screenings done before. They check mommy and daddy, with blood tests before. But then after birth, we can look at doing sweat tests on them. And again, it's just these little probes we put on them and it measures the sodium on the skin. Multi. What is included in the plan of care for a child with cystic fibrosis? Remember the one thing about cystic fibrosis, it's not just lungs. We think of cystic fibrosis and all of the mucus in the lungs, but remember, mucus is everywhere and it's in the intestinal tract that we have to work with. Remember, the pancreas is involved and it cannot absorb fat. So keep them away from fat. We want them on high protein, high carbohydrate diet. You're not going to hold sodium. They're sweating it out like crazy people. They need more sodium, salt. Give them a salt shaker. And again, keeping those lungs nice and clean, aggressive chest physiotherapy. They've got those vests, those vibrating vests, which are pretty neat now. You put them on, and they really help. It's like you don't have to with their hands like we used to have to do. And of course, those pancreatic enzymes. What is the drug of choice for pharmacological closure of a PDA? So we need that thing open from the aorta to the pulmonary artery. I need to get oxygen to the body. So I need to keep it open, but mommy's not here anymore. And now I need to close it because it's there too long. And that's called indomethacin or indocin. Prostaglandins keeps it open. That's a hormone that mom supplies also. That keeps it open. Indomethacin is an NSAID. It closes it, gets rid of it. Synagist is for RSV. And vitamin K is a shot they give at birth to stop the bleeding. What is not a feature of tetralogy of Fallot? Remember I told you tetralogy of Fallot is on the right side, has to do with the pulmonary artery. So when you look at tetralogy, always think right side. So what's not? It has to be something from the left side. Which ear is left-sided? And that's your answer. Aortic stenosis. The VSD, it's both sides. It works. Pulmonary artery is right-sided and right ventricular hypertrophy, the stretching is right side. What medication would you hold for an infant that's vomiting and vital signs are 98, 88, and 32? What do you think is going on? And I want you to know every medication I wrote down here can be given to an infant. And that is digoxin. Enalapril is one that helps strengthen it. Metoprolol has to do with those heart rates that keep going up and down as a beta blocker. And hydralazine, blood pressures. I mean, all of these things are used with even young infants. Why would a child with tetralogy of Fallot not gain weight the normal rate? Remember, tetralogy of Fallot is considered a cyanotic heart defect. Cyanotic heart defects, we worry about oxygenation. You don't have oxygen, you have no energy, and you're not going to eat. Therefore, you're not going to gain weight. Any congenital heart defect, that includes. Very good. A multi. All are examples of cyanotic heart murmurs, except cyanotic, which isn't. So we know tetralogy is cyanotic. I tell you, they go blue, blue baby, TET spells. ASD is an opening between the right and left side. There is oxygen still going around. Aortic stenosis is just a kink. There's still blood going around. To tricuspid atresia, A, without. There's no opening between the right atrium, right ventricle. Nothing's getting to the lungs. That's why those two are cyanotic. A multi. Nursing education for the cardiac catheterization include all except. So you're not going to be able to ambulate. It's 24 hours bed rest, and you need to keep that leg straight. Again, to prevent the clot from being dislodged. Which information is the most important when rheumatic fever is suspected? So what is rheumatic fever caused by? And our biggest concern is, rheumatic fever happens, they come in, sore throat, swollen glands, they have a rash. The thing is, they've had a sore throat, then we have to diagnose it, and we'll do that ASO titer. What is the treatment? Long-term antibiotics, and the only thing that we cannot fix is the heart valve damage, and it's usually a mitral valve. Signs of shock in children include all of the following except what's not shock? So you have hypotension, we have tachycardia, and we have the rest, okay? With shock, your blood pressure falls on the floor. We got to get it up somehow. Which of the following best describes the pathophysiology of Kawasaki disease? So again, Kawasaki is that vascularitis, the inflammation of the vessels, and we're worried about clots. IVIG and aspirin, we're worried about those coronary arteries. Multi. A clinical manifestation of Kawasaki is? What do you see? What do you look like? So we have a little bit of everything. It is Korea too. Um, on this one, that's rheumatic fever. Korea is rheumatic fever. Kawasaki is your blistered hands of your feet and your soles, the reddened eyes, strawberry tongue, and maybe a rash on it. Okay. Korea, again, that's rheumatic fever. And again, it can be cured with the antibiotic. What is the treatment for Kawasaki disease? Rheumatic fever is long-term antibiotics because it's from a strep infection. Kawasaki disease, it's a systemic vascularitis. So we're going to give aspirin and IVIG. Yes, it is not a bacterial infection. Which of the following is the most common cause of shock in infants and children? And I look at this baby and I see pointed ears and a tiny chin, and I know this child's at the George syndrome. And that child's more susceptible to shock as I look at it, believe it or not. But it's infection. Children don't have an immune system. They can't fight it. You give them an infection, overwhelming sepsis, they can die very quickly and easily. What are the defects associated with tetralogy of Fallot? Remember, tetralogy is mostly right-sided stuff. This is how I remember it. It has to do with blood's not going into the pulmonary artery and into the lungs. The one thing is that misplaces aorta. It's like the aorta just moves over a little bit with all of the way that, the locking of things, but it's all right. PA, your pulmonary artery is closed up. You have that VS stay. And of course, that right ventricle gets stretched when that pulmonary valve closes. It stretches the ventricle, and that's why hypertrophy. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. Kids just tend to do this, and I don't know why. Mostly today they are fixed. They just squat. They just sit and they squat. It's like that does change the pressures in the abdomen and the chest, and it works. Transposition of the great arteries is what? What are the great arteries in a heart? It's the pulmonary artery and the aorta. What is transposition? Or they're transposed. They switched. That's simple. Very good. What is not an intervention indicated for transposition of the great arteries? Well, let me tell you, transposition of the great arteries is an extremely serious condition. There's no oxygen going anywhere. So this is like you have to massively treat it, okay? Which means there's no oral anything here. This is IV prostaglandins. Let's get that PDA open. Let's get oxygen. Let's take up the tops, move them, put them back. And that's the surgery called arterial switch. They also go in and take that patent foramen ovale in between those atrium and make it bigger. And again, let right and left side oxygen exchange in there. This is a huge, huge, huge diagnosis, but these children do well if we can keep that duct open and oxygen going to those children. Sorry. Why is prostaglandins given to a child with transposition of the great arteries? There's two purposes. Transposition of the great arteries. You don't have oxygen going to the body, right? You have absolutely heart's beating and it's doing absolutely nothing there. You need it for oxygenation and cardiac output. That's it. Has nothing to do with infections or endocarditis or any of that stuff. What is the purpose of giving indomethacin to a neonate with a PDA? What does indomethacin do to the PDA? How do PDAs keep open in the first place? It basically says prostaglandins, yep, you're over with. No, we're going to close you up. And that's what happens. It inhibits what's ever there and it stops it and it closes it. Where is the patent ductus arteriosus? Remember, it has everything to do with oxygen. This is your oxygen giver to the body. Oxygen, pulmonary, body, aorta, artery, artery, period. Did that make sense now? This heart defect allows blood to pass from the left ventricle to the right ventricle. It's a hole in the septum. What is it? VSD, ventricular septal defect, in between the two ventricles. Yes. A multi-select. What is a sign of ditch toxicity in infants? So that nausea, you might see retching in infants, but nausea vomiting is a big thing. And then, of course, the heart rate is low. You're not going to see yellow spots. Which infant's going to tell you I have yellow spots? It ain't happening, okay? And ditch toxicity has nothing to do with infection. It's vomiting, low heart rate, low potassium rate, and elevated ditch levels that you wouldn't give it. So those are things you look for. Left-sided congestive heart failure causes. The left side of the heart, when it's all swollen up, what happens? Goes to the lungs. Yes, very good. After a heart transplant, what is a leading reason children die? And the two things that are there you say is rejection, infection. Which one is it? It's rejection. Very good. A multi. Signs and symptoms of rheumatic fever include. Remember, rheumatic fever is due to a strep infection that wasn't treated or undertreated. And remember, everything goes away except for heart valve damage, okay? It does cause, the sore throat. It causes swollen glands, respiratory, polyarthritis, those nodule joints, and that weird movements. Again, all of that goes away with long-term antibiotic therapy. Sorry. The child's about to have a chest tube removed. What should you do? For all kids in cardiac surgery come out, they have a minimum of one, up to four, seen five chest tubes in, depending on what they've done in there. And the one thing about kids, do never lie to them, especially cardiac kids coming in for multiple surgeries. They'll never forget. Always explain it to them what's going on their level. Tell them it's going to hurt and please medicate them. They're going to be sitting in a high Fowler's position. They're not going to be on their backs. No, flat, because that will burn. They have to be their head of their bed elevated. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's your priority? The child's going to get pneumonia if we're not coughing, isn't it? And how are we going to make them do that? We're going to medicate them for pain, or they're not going to do nothing. What would you want if you needed to cough and deep breathe? You need pain medicine, then get out of bed, then use it instead of spirometry, changing positions, etc. Number one, pain medicine. Make it not hurt. An infant 3 months has a fever of 103.6. What would you medicate the infant with? Only Tylenol till 6 months. And at 6 months, you can add ibuprofen, okay? Only acetaminophen for 6 months. A newborn infant's assessed and you find very weak lower extremity pulses. What should she assess next? So I don't feel my pedal pulses. What do I need to do? And what am I looking for? I think you got this one now. And it is for extremities, blood pressures, your understanding. Blood's not going down, it's up here, and you're going to prove it by higher blood pressures up here. Excellent. Die. Critically ill child's on complete bed rest. What can a nurse do to prevent complications? Now, children do get critically ill, and some are in there 6, 8 months, pretty sick. And you think only adults get decubitus and, pulmonary complications? No, children can too. So, instead of spirometry, keep them dry. Use blankets, pillows. I use little toys, little beanie babies by the tracheal tube. Something cute to look at. Elevate the head of the bed is only if you're allowed to. Sometimes you can't. And how can oxygen be delivered as easy as tolerated and accurately monitored for infants? This is from last week, just giving it to you again. And yes, it's an oxy hood. Everything else is more uncomfortable or taped on. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, cystic fibrosis is multi-system. It's not only lungs, it's also, digestive, nutritional. So when we think of it, remember, it's both things that we worry about. Deep breathing, chest CPT, exercise, and ambulating, not PRN. QID would be the ideal, right? Multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? This are also going to be one of your NCLEX questions, usually, that you come up with. So you take it right before meals and snacks. You can sprinkle it. You can also put powder on it, but rinse your mouth when you're done. And the other thing is to make sure you increase the dose as they get older. It's what we always forget. What is a cardiac defect where there's no valve between the right atrium and right ventricle? Well, what is the name of the valve between the right atrium and the right ventricle? We have things, a mitral valve, the aortic valve, the tricuspid valve, and the pulmonic valve. Which one is it? And it's tricuspid atresia, A without tricuspid valve. And last question. When an infant is breathing fast, tires easily, needs rest periods during feeding, what should you assess? What do you think is going on? Breathing fast, tiring easy. I need rest breaks. It's going on my lungs. I'm going into failure. Be good, guys. We made it. Yeah, Jerry, look at that. Brandy, doing good today. Hannah, and Lucille, and Ashley, good job, guys. So remember, this week you still have a discussion question and you do have a CJ Sims. I've put some messages if it's you who hadn't sent me something to let you know, get it in by Sunday. Remember, look at your pediatric assessment project. Anybody who hasn't sent in what you want to do, let us know so that we can approve it. Any questions by anybody? Thank you all. I'll be sending you all the recording so that you all have it. So don't worry about that. Have a great evening, guys. Thank you.